Welcome you all. My name is Dr. PG Madam Rafi. Today we are going to discuss about diuretics. Okay. So first of all, what is diuretics? What they will do? Diuretics mainly inhibit renal tubular reabsorption of sodium and water. By inhibiting renal tubular reabsorption, they will increase the urinary volume. Okay. So based on their ceiling effect, these drugs are divided into high ceiling, medium ceiling, and low ceiling drugs. Okay. So in high ceiling drugs, we have loop diuretics, osmotic diuretics. In medium ceiling diuretics, we have thiazide diuretics. In low ceiling diuretics means they will excrete less volume of urine. So in this we will have carbonic anhydrase inhibitors and potassium sparing diuretics. Okay, based on the ceiling effect. Now we will see which drug will act on which sides. Okay, diuretics acting on proximal tubules. That means in the proximal site. Okay, here will the drugs will be carbonic anhydrase. Okay, so by inhibiting carbonic anhydrase, they will enhance urinary volume. Next is drug acting on loop of Henle. This loop of Henle, descending loop of Henle, ascending loop of Henle. So in this loop of Henle, we will have loop diuretics, osmotic diuretics. Mostly these two will acting on ascending limb of loop of Henle only. Okay, not in the loop of Henle. They will acting on ascending limb of loop of Henle. Next is drugs acting on distal tubules and collecting ducts. That means in the DCT and the collecting ducts, those are thiazide diuretics and potassium sparing diuretics. Okay. If you observe here, in the cortical region, this nephron will be divided into cortical and medullary region. In the cortical region, obviously, what will happen? They will lose water. Okay, if you see here, they will lose water. They will make urine volume more. Okay, if you see in the medullary region, they absorb water morely. Here, urine will become very concentrated. In the cortical region, urine become diluted. Okay, that is a major physiological difference. Okay, if you see in the medullary region, in the medullary region, obviously more water will get absorbed, more sodium will get absorbed. So obviously this volume will be reduced. When you see in the cortical region, obviously there will be more sodium will be flushed into the tubular. Obviously what will happen? More urine volume will be there, urine dilution will be there. Here urinary concentration will be increased. Okay, there is a major fundamental difference. You should remember. Okay. Next, we will see each group of drug, how they function and their adverse effects in the following slides. We will discuss carbonic anhydrase inhibitors. Okay, in carbonic anhydrase inhibitors, we will have drugs like estazolamide, dorzolamide, brinzolamide. Okay, so before discuss about uses and side effects, we'll see the mechanism of action of this enzyme inhibitors. Okay, so first, carbonic anhydrase will be beneficial and it will be useful in formation of carbonic acid and breaking of carbonic acid. Carbonic acid breaking is done in tubular lumen and this formation will be happening in tubular cell. Okay, if you see here, this H plus ion combined with the bicarbonate and form carbonic acid. This carbonic acid will break down by carbonic anhydrase enzyme and it will be divided into hydrogen and carbon dioxide. These both are absorbed into tubular lumen and in tubular lumen this carbonic anhydrase enzyme will useful to convert into carbonic acid. Okay. So after conversion there will be further divided into H plus and bicarb ions. This bicarb ions will absorb into tubular blood supply and they will be entering into the circulation. Okay. Next, this H plus ions will secrete into urinary lumen. That means tubular lumen. Then further, this bicarb will be bind and this cycle will be continuously going on. Okay. So now we are giving drugs like estazolamide, dorzolamide. These drugs will inhibit this carbonic anhydrase enzyme. So when these drugs inhibit this enzyme, what will happen? The breaking will not be happen and the formation of carbonic anhydrase will not, this carbonic acid will not be happen. So what will it leads to? There will be losing of bicarbonate ions in the urine. So continuously losing of bicarbonate ion, what will happen? Alkalization of urine. When bicarb is continuously flushing out, what will be compensatory? Metabolic acidosis will be formed. Okay. So this is how the mechanism of action of the drug. So we will see the uses. This is the first use, that is angle closure glaucoma. Angle closure glaucoma, what will happen? Increase intraocular pressure. There will be more aqueous humor production. So these drugs will inhibit this production. Okay. Second is alkalinization of urine. I already explained. Okay. Because of continuously losing of bicarbonate ions, obviously leads to alkalinization of urine. When urinary acidosis will be there, in those conditions we use these drugs to make urine to alkaline. Okay. because urine acidic will make burning micturition, so we have to make alkaline and nephrotoxic also. So we will use urinary alkaline drugs that are this esdazolamide, dorzolamide. Second in third one is mountain sickness. Okay, these drugs are side effects. They have major side effects. These drugs are sulfur drugs. Okay, so because of the sulfur drugs, they will have bone marrow suppression and hypersensitivity reactions. Okay, and metabolic acidosis, why? Because of losing of more bicarbonate ions in the urine, body will compensate and form metabolic acidosis. Next is hypokalemia, because when hydrogen ion is excreting, these drugs will block hydrogen ion. Okay, so when H plus is blocking, obviously they will be compensate to excrete potassium. So when hydrogen is blocking, to compensate, there will be some ion will be exchanged with sodium. So that ion will be potassium. When more potassium will be losing, obviously leads to hypokalemia. Next is hepatic encephalopathy. Hepatic encephalopathy, why? Means where NH3 is ammonia, it will convert into ammonium by help of H plus ions. Okay, when these drugs are inhibiting excreting of H plus ions, this NH3 will not be converted into, that means ammonia will not be converted into ammonium. When it will not be converted into ammonium, obviously it will not be get excreted. It will be get accumulated in the body and leads to hepatic encephalopathy. Not in all patients. Patients who are acute liver injury and hepatic diseases patients, in those patients they will have tendency to develop hepatic encephalopathy when you are using carbonic anhydrase inhibitors enzymes. Okay, next group of drugs will be loop diuretics. Okay, loop diuretics will have drugs like furosemide, bumetanide, torsemide, ethacrenic acid. They will act on thick ascending limb of loop of Henle. Okay, mostly we will go with answer like loop diuretics will act on loop of Henle. No, it will be acting on ascending limb. Okay, not descending. Ascending limb of loop of Henle. They mainly inhibit sodium potassium 2Cl minus importer, and these drugs will have minimal carbonic anhydrase inhibitor activity. This is the drug of choice because these drugs will lose more water. So these are the drug of choice for pulmonary edema and moderate to severe renal failure. They will decrease renal burden. So that we can use these drugs. And to treatment of hypercalcemia. Why hypercalcemia? Hypercalcemia means there will be more calcium level in the blood. So what will happen? We have to be exceed the abnormal level. So these drugs will lose calcium. Loop diuretics will lose calcium. So that means they will excrete calcium. Thereby they will control the calcium level in the body. Next is this adverse effect will be hyperglycemia. That's why we will not in diabetic patient. Hyperuricemia is there, so we will be cautious when you are reading in gout patients. So mostly gout patients also we can't use these drugs. Next, hypokalemia will be there, hypomagnesemia, electrolyte imbalance will be there, and ototoxicity. Okay, this is a major adverse effect. Diuretics will have loop diuretics, that's true. Loop diuretics will have chance of developing ototoxicity. That too mainly ethacrenic acid will have more chance of developing ototoxicity. Okay, next we'll discuss. Next group drugs is osmotic diuretics. This group also acting on same loop diuretic, this loop of Henle only. So this mainly is, what are the drugs in this group? We have mannitol, glycerol, urea, isosorbate. Okay, they were asking, we will mostly remember mannitol and glycerol. Urea and isosorbate also belongs to this group only. Next is how these drugs will act. Increase osmotic pressure. How they increase osmotic pressure? They by leading to rise of extracellular fluid volume. Means these drugs will absorb more volume of fluids. Thereby they will increase ECF volume. Obviously, once ECF volume will be increased, plasma volume will increase. So increase renal blood flow. So thereby increase GFR. Okay. So that means these drugs will absorb more volume of the drug, more volume. So thereby increase extracellular fluids, thereby increasing plasma level. So obviously more blood volume will be there. So more GFR will be happen. So what are the indications of osmotic diuretics? So they will be useful in edema. Obviously, because in edema patient there will be more water accumulation. So obviously we need these drugs to flush out of this excess volume of drug, the excess volume. Next is acute congestive glaucoma. Next is acute congestive glaucoma. Also there will be more acrosomers, so we need these drugs to flushing out of all those things. Next, prevention of cisplatin induced nephrotoxicity. Okay, this is an MCQ. Osmotic diuretics will be useful in cisplatin induced nephrotoxicity. And what are the major thing is, there will be some contraindication conditions. We will not use osmotic diuretics. What are those? Pulmonary edema. Why in pulmonary edema? Pulmonary edema, obviously there will be more fluid accumulated in the lungs. Once you are giving these drugs, there will be more ECF will be there, more volume will be there, more accumulation of fluid in the lungs will further will be there. So obviously there will be more fluid will be accumulated in the lungs. What will happen? More congestion will be there. So in those patients, these drugs will be contraindicated. Next, acute renal failure patients also will not use diuretics. Okay, that means osmotic diuretics will not use. We will go with loop diuretics. Okay, because loop diuretics they will flush out more this one. If you are giving osmotic diuretics, they will enhance more volume. So obviously more burden on the kidneys will be there. Okay, obviously if more burden will be there, there will be more renal failure, more chance of renal failure will be happen. So we will avoid in acute renal failure, pulmonary edema, and active cerebral bleeding, because they will have more chance of hemorrhage. Okay, because if acute bleeding is there, obviously this drug will be acting and enhance more bleeding. So we will avoid in these three conditions. These are very most important. Okay, you have to remember what are the contraindications of matter compared to uses. Okay, because contraindication will be very important. Some these drugs will not use in this condition, that because they will have life threatening. Means pulmonary edema also life threatening, cerebral bleeding, hemorrhage life threatening, renal failure also life threatening. So we have to be remember. Next group of drugs will have thiazide group. Okay, this is the first line group. Now we are using as an antihypertensive. So in those we will have drugs like hydrochlorothiazide, indapamide, metolazone, other group drugs also there. We will see all these three main drugs only. So these drugs inhibits mainly sodium chlorine symporter, acting on these drugs acting will a distal converter tubule. Okay, and these also have minimal carbonic anhydrase inhibitory action except indapamide drug. Okay, other than indapamide, rest of all drug will have carbonic anhydrase inhibitory action. These are the first line agents. Now we are using as antihypertensive, and reduce excretion of calcium. Okay, mainly thing if you are seeing, that's why we will use in hypercalciuria renal calculi patients, because loop diuretics they will have chance of renal calculi. Okay, because they will lose more calcium. More calcium will be leads to more accumulation of formation of stones in the ureters. So those patients will have more chance of renal calculi. But if you are prescribing thiazide diuretics they will not lose calcium. Okay, so these will be safe. If the patient is having hypercalcemia, in those situation we can give. But if the patient is having chance of renal calculi, we can't give these drugs, because loop diuretics will have more chance of renal calculi, but thiazide diuretics will be safe. In those patients we will give. So because these drugs will reduce the excretion of calcium, so we can give in hypercalciuria patients and renal calculi. Okay, so in those patients, renal calculi patients also thiazide diuretics will be beneficial, because they will not lose calcium. Next is hypercalciuria. Also in those patients also will give, because they will reduce calcium excretion. Okay, so in those patients, thiazide diuretics are main drug of choice. These drugs adverse effect will be similar like the loop diuretics only. Hyperglycemia, so avoid in diabetic patients. Uremia, also avoid in gout patients. Hypokalemia. Other than these three, erectile dysfunctions. Okay, these thiazide diuretics will have chance of developing erectile dysfunction in elderly males. So we have to be more cautious. And these drug interactions will be, they will decrease excretion of digitalis. So digitalis toxicity will be happen, and they decrease excretion of lithium. So obviously lithium toxicity will be there. So when your patient is on digitalis and lithium, should be cautious with prescribing of thiazide diuretics, because they will have more chance of developing digitalis toxicity and lithium toxicity. Okay. Here main MCQ will be this one, hypercalciuria renal calculi. Patient is on renal calculi, drug of choice of diuretics will be thiazide, because in those patients the thiazides will not lose calcium. Okay, like that they will ask. So you have to remember what are the indications and adverse effects, mainly erectile dysfunction, then toxicities. Next. So next we will have potassium sparing diuretics. These potassium sparing diuretics will act on distal tubules and collecting ducts. Okay, they will be two types: epithelial sodium channel inhibitors, aldosterone antagonist. Epithelial sodium channel inhibitors means they will inhibit epithelial sodium So obviously there will be no potassium loss. Okay, so when there is no potassium loss, obviously potassium will be spared. So that's why these drugs will be beneficial. So these drugs, what are the drugs in this group will have amyloride and triamterene. In this amyloid is lithium induced diabetes insipidus drug of choice. This is an MCQ. Lithium induced diabetes insipidus will be treated with amyloid. Okay, and we will use it as a cystic fibrosis condition also as aerosol means spray like spray we will use in cystic fibrosis condition. Next group drug is aldosterone antagonist. In this aldosterone antagonist, what are the drugs? Spironolactone, eplerenone, canrenone. These are weak diuretic action drugs used in combination because loop diuretics, osmotic diuretics, carbonic anhydrous diuretics, thiazide diuretics, all these diuretics they will use potassium. So to compensate potassium loss, we will add aldosterone antagonist. That's why it is used in a combination therapy. Okay. So, and some cases will treatment of hirsutism also will use. Mainly adverse effect of this aldosterone antagonist will be gynecomastia. This is an MCQ. So many times it is repeated, gynecomastia, and impotence, hyperkalemia. Hyperkalemia also happen when you are adding with ACA inhibitors, that is angiotensin converting enzyme inhibitors, and ARBs. These two are potassium sparing. This drug also potassium sparing. So when you are combining ACA or ARBs with aldosterone antagonist, what will happen? Obviously more potassium will be get retention, leads to have cardiac arrhythmias. So this is most repeated MCQ. So we should not add ACA inhibitors and ARBs when you are prescribing aldosterone antagonist. So if your patient is on potassium sparing diabetes, you should not add ACA inhibitors and ARBs. Okay. So in potassium sparing diabetes, what are the drugs will have? Epithelial sodium channel inhibitors and aldosterone antagonist. That's all. Thank you.